I was just discussing with Gustavo Malinga that it seems to be a dangerous place to live in Nice and in Monaco, if you see all these things. But he told me, don't worry, it's dangerous for the heart to be in Berlin, it's dangerous for the brain to be in Israel at his place. This is why this is the disadvantage of experienced speakers giving talks on rare conditions. Well, I remember many years ago I was at a meeting, it was in the States somewhere, and we had a discussion on early fetal echo, and one of the American colleagues was asked, what do you think about early fetal echo? And he says, yes, I like it very much. Every morning between 8 and 10, the fetal echo I do is an early fetal echo. And the people were laughing like this. I was disappointed because I was prepared to give a nice talk on early scan. And this is why when I give a talk in the early morning, people will think, well, because it's anomaly scan in the early morning, it's an early anomaly scan. But actually, now we are more involved in these things, and I try to reduce my talk into, let's say, the main anomalies we can see. I will not cover everything. I want to show you my talk some aspects on what are the typically detectable anomalies. And you will see that some anomalies may worsen during gestation, some may resolve, and some may develop between the first and second trimester. And let's say my hope is at the end that the limitations of detecting anomalies is not your skill or your machine, but mainly the natural history. Because there are some things you can see in the second trimester, but you know by definition that you may have seen it in the beginning of gestation. In the 90s, there were a few group of very famous people who were saying that they are able to do many things in early gestation. Something we can see the heart, the other one can see the brain, the other one can see the embryology. But they were invited to many courses and they were showing off this is what we can do. And I used to belong to some of these, saying, well, we can see the heart at 13 weeks, and no one, let's say, said I'd be able to do it. And then one day came Kipros, and he said, guys, you don't need to do these things. You need to do only the nuchal translucency. Everyone can do it. And people said, yes, it's true, we can do it. And then people started to detect fetuses with thickened nuchal, and some of these had trisomy 18, and they saw, oh, I can see an omphalocele, I can see a large bladder, and if you look at the heart, I can see some abnormalities. And he said, once you are looking at the face, you can measure the nasal bone. He said, yeah, it's no problem, you can measure the nasal bone. Oh, you can measure the ductus venosus. Yeah, you can measure the ductus venosus, and some measured the hepatic vein and think it's the ductus venosus. And step by step, people got into the first trimester, and we are now there that we can see many things. Now, we had a discussion with Kipros a couple of years ago about, the work Bernard was preparing. He said, is there a way that we can move earlier? And let's say the major handicap for us is not the quality, because what he showed you today, probably most of you will do it in 10 years from now, because what I'll show you today, everyone can really do it. The main problem what we have in early gestation is, can we confirm how are the chromosomes? And we cannot do it before 11 weeks until now. There was some approach to do cystoscopy and so on, but if we have a technique to confirm chromosomal abnormalities at 8 weeks, let's say in an invasive way, safely, then we'll go in this direction. And this is why Kipros said, guys, measure the ductus, measure the angle, measure the tricuspid, and so on. And now he's saying, rule out anomalies because you can do this, and I hope you will listen to him and go this way. But the main message over the years were that we are now not doing nuchal measurement. We are doing early anomaly scan where the nuchal measurement is a part of it. And this is why we are moving toward a comprehensive anomaly scan. What are the prerequisites? The prerequisites are, on one hand, personal. That means you should be very good in the second trimester scan. But don't assume it is the same way of scanning when you go in early gestation. It is quite different. And you should be very rapid in adapting to the new fetal position. It's, for me, by far easier to to do rapidly a second trimester than to do a first trimester, because you spend a lot of time sometimes and the baby is not really moving and is hiding, and there is a bowel of the mother. You go transvaginally and you see the feet but you don't see the head and so on. It's not that easy. But you should also understand the fetal development, especially that you have heard what Bernard was saying, and you should know how to manipulate the machine, because if you have the probe transvaginally and you want to check something and you don't know where is the knob, you don't have time to think, let's try this, and you have only one hand and you should have good presets. What I will not give you today, but I give you on the handout, is to examine systematically. If you don't do a systematic approach, you will always forget many things. And this is why the first step, and this is the major mistake of many people, the first step of early anomaly scan is that people are used to scan, like in the second trimester, rapidly, and they see the indirect signs. No amniotic fluid means there is no kidney, and large fluid in the brain means there is a brain abnormality. In early scan, things may be different, and you should get typical planes systematically, otherwise you may miss things. You may miss a complete arm if you don't look for this arm. Believe me, even if you go transvaginally, it's not that obvious to see all these things. You should have your short list to check. And technical, of course, I will let you know that you need an excellent equipment, but actually you need a good equipment, and all transvaginal probes since the mid-90s are so good, and the quality is increasing. And you should combine, if you have a problem, abdominal and transvaginal, and combine 3D with color Doppler and with 2D and so on. In my place, we are doing, let's say, nuchals and early anomaly scan a lot. And roughly speaking, I do between 80 and 90% of my exams trans-abdominal. And we try to get the patient first 12 plus 5 to 13 plus 2 around this period of time. Sometimes for the nuchal measurement, we try to have the biochemistry before. But in cases where the fetus is less than 65 millimeters, or in cases, or let's say below 12 weeks, I will always complete with the transvaginal approach. Or if I have a very high risk for a specific condition, I had last week a patient with a kidney problem in the previous pregnancy, and then I will go and show that I see both kidneys, let's say, very clearly. Even if I see them abdominally, or for the heart, if there is a severe heart problem, I will go transvaginally to show that, let's say, I was awake, or I was, let's say, intended to examine specifically this organ in a proper way. I don't believe, it depends on the setting. I don't believe that we should do on all automatically or transvaginal, because, let's say, the way you are scanned, you never be able to do a nuchal scan, only the transvaginal. You need an abdominal way. And if you do on a low-risk population, that means where you expect 1 out of X thousand cases, 1 case, all transvaginal and so on, it's the time you spend for this, you need more than half an hour or an hour. And this is not, let's say, the clinical setting. This is why many things can be seen abdominally, but you need really big experience. Now, the difficulties are, of course, you may perform nuchal, you do an early anomaly scan, and you see easily anencephaly, hydrops, omphalocele megacystis. But there are challenging problems like movements and position of the fetus, and many anomalies, as you know, may be obvious as late as 20 weeks and more. And most of the talks we are giving today on the cerebellum, on the corpus callosum, etc., will be late apparent problems rather than the one you can see in early gestation. And let's say one of the problems we may have in early gestation is that because we start doing early anomaly scan by looking to the nuchal measurement, we have a kind of feeling or belief that if the nuchal is thickened, there is going to be a big problem. But if the nuchal is thin, it will be an okay child. But in this condition, no one can tell you that there is no spina bifida. You cannot say that the fingers and the arms and the legs and everything and the kidneys are there. Because you don't know. You assume, let's say, in your brain automatically, because the nuchal is thin, it should be a normal child, which is not true because you are doing screening. It's like doing screening on a second trimester, plus many of the signs we have in second trimester we don't have in early trimester. This is why one of my main messages is that what you should do is to go systematically by getting longitudinal view, views and getting axial planes and then coronal planes. And this is how, personally, I scan. I start doing, let's say, the measurements, and then after the measurements, I get a longitudinal view of the fetus to check out the face, the abdomen, and the relationship, and then get a magnification of the face in longitudinal and then axial planes, and the same for the thorax, abdomen, and for the limbs, we go to the right and to the left to see these things. Now, biometry, in my opinion, should be more than measuring the CRL. In our setting, we measure the CRL plus. Plus means the BPD, the head circumference, abdominal circumference, the femur length, and sometimes additional things as the structures within the brain. And this is standard planes. Why? If you measure the leg, you are obliging yourself, or measuring the femur, obliging yourself to watch the feet. If you measure something, you are obliging yourself to put it on your checklist. This is why I measure personally the IT and so on to let's say, not to avoid forgetting, have I seen it, yes or no. It's like measuring the cerebellum. I measured the cerebellum for more than, 20 years, or I don't know how long, 25 years doing ultrasound. But let's say the cases of having cerebellar hypoplasia, only detected by measurement, are less than 10. But we measured thousands of thousands only to be attentive that we are really measuring something. That means we have seen it and it is there. And if you measure the leg, that means you are looking for the legs. And occasionally you may see an early skeletal dysplasia. Now, the mid-sagittal plane, as I told you, is one of the most important things. This is one of the best planes you can get, and then you move to get different parallel planes. And this is here a transvaginal approach where you see going from the head lower to the thorax. You see some pericardial effusion at this stage. This is 12 weeks plus 1. With high resolution, you may see some bowel remaining here, and then the legs, and then you move to the feet. I find personally more difficult to do it all vaginally because you don't get the planes. You get some parts of it in comparison to the abdominal approach. Unless you have one organ you are looking for in the body, then it's easier to go transvaginally. Let's start with the brain first. I will always check the head within these planes. That means a cross section of the head where we can recognize these kind of butterfly-shaped plexus, choroid plexus, with the falx, with the ventricles, and with the posterior fossa. In some, if you are examining transvaginally, of course you will go and observe what is happening at the level of the cerebellum and the fourth ventricle and the choroid plexus. And then we see also not only the face, but also the brain from the mid-sagittal view, where we can recognize here the thalamus and the brainstem. What the parents ask, the baby has big ears like my husband. They say, no, this is the brain, a small brain like your husband. But, and you move to the axial planes, to the coronal planes to look at the spine and the ribs, and then you go inside to see the kidneys. And you may look at the spine this way, but believe me, you have seen in later gestation some cases with the miyolocele where you don't see, let's say, a kind of bulging, and you may miss small spinal bifida at this stage. This is why it's not even safe to say, well, the spine is normal, because it looks normal. Now, what are the typical abnormalities we can see? We have seen these, unfortunately, already at 8 weeks. This is why it's now easier to recognize that you can recognize anencephaly, or this case here. These are standards. You can recognize that you don't need to measure any nuchal here because you have acronia and exencephaly. At this stage, the brain is still there. But interestingly, the shape of the head in all these feet is really different. If you look at 3D. Later on in gestation, most part of the brain will have been digested by the amniotic fluid, and you see the typical acronia. And this is another case. You see the shape is quite different than the other one. This is where there is no single image of acronia exencephaly, but this is something everyone can see. At latest, when you start looking for the axial plane and you want to measure a BPD. The next, what you saw before, it's easier than what Bernard showed you, the holoprosencephaly with the lack of the midline. And this can be recognized easily by transabdominal view because you want to measure the brain. In general, the size is already small. and you go transvaginal in another case, and this is what you see, the alobar holoprosencephaly. But some cases are more subtle, and this is why when you take this image, you may think that there is a flux, but if you go a little bit lower and higher, then you see that there is a fusion of both. This is why sometimes when you listen to it, you say, well, this is something I know, pass over, give me the next one. But it's not always like this. Sometimes if you have some suspicion, the size is abnormal or the shape, try to get more. And if you are not sure, go transvaginal because you have to confirm this. This is such a severe condition, you should not be missing these in early gestation. Now, of course, you expect me to tell you a few things about the intracranial translucency. I'm sure that some experts like Gustavo may recognize at 13, 14 weeks in other planes, transvaginally, the abnormality. But the message is that if worldwide people are doing on many fetuses the nuchal measurement and the nasal bone measurement, why not to look to the brain? And what you see here is the thalamus with the brainstem, and the posterior wall of the brainstem is echogenic, and the plexus corridor is echogenic as well, and the fluid between is called the intracranial translucency, which actually is not the fourth ventricle per se, because the fourth ventricle is still connected with the future cisterna magna, is the whole fluid here. But we say IT for this. Now, in the first observation, we saw that under normal conditions, there is fluid here, and in the few cases of spina bifida, there was a complete compression of this region. But in the meantime, we know that there are cases where, due to the leakage of this fluid within the brain, there is a kind of more or less compression and a reduction of fluid. But the typical image of border over IT is absent. If you want to know more, go for the White Journal for the last issue of December. There are many articles dealing with this, and an opinion we wrote, Kipros and me, on this condition. And this is how things appear. In the past, you were maybe looking for the nasal bone and so on. Now you know that this was one of the recent cases I detected by routine scan in a 30-year-old a young lady. And you see here that this is a thickened brainstem, and the distance to the occipital bone is short because there is no typical region here compared to this lot of fluid. And this is here during the routine measurement, and I wanted to measure something. I couldn't put the dots anywhere because I don't see the clear floating fourth ventricle. And then I went to, this is how it appears. And by abdominal, I couldn't be sure that there is a spina bifida. I went transvaginally. And this image, I will not be sure. I waited until the fetus jumped, and I could see this 4 millimeter spine. And then turning around and waiting and hitting the abdomen, then you can see the small spina bifida in the lumbosacral region. I tried to convince the lady to wait for 2-3 weeks until we see the lemon and banana signs, but she said, for a second opinion, I want to terminate pregnancy, because it was, for her, then obvious. When you render on 3D, you see it. To be honest, I'm sure on my routine scan, knowing that this anomaly is 1 out of 1,000 to 1 out of 2,000, I'm not sure that I would have seen it under other conditions. Because you will scan, there is a low risk, there is no risk of anything else. The brain and the size, everything is normal. You pass over, see it's normal. If you don't look for this new sign. And if you look at data of many centers, many have a good detection rate of Down syndrome, but a very low detection rate of spina bifida. This is why I hope that it can help this or that person. Now, the other face of the medal, that if you see an increased fluid here, you may think it's Dandy Walker condition. Now, there are really a big difference between what we are speaking about, because if it is reduced fluid, you have a control as looking to the spine, transvaginally, a week later, and so on. But here, you cannot predict that there is no vermis going to develop. And this is why what we see here, we see more fluid. And in this condition, with an absent nasal bone with a thickened nuchal, you may see, of course, it looks like a trisomy 18, and it was 1. But if you have more fluid here, the only thing you can do is you have to be careful, and you have maybe to call back the woman to come back at 18, 19 weeks, where you can have a next control, and then to be sure. If there is a recurrence case, this is not a good sign at the beginning. Now, this is why we have to be careful. Now, this is a case I show you 13 weeks with that dilated posterior region, and we said you return back at 15 weeks that you can measure the cerebellum. And after 15 weeks where we used to do amniocentesis and so on, there was no cerebellum to be measured. And the fetus had, in addition, a cardiac problem. That means this, at 15 weeks, plus the cardiac problem was for the woman a reason enough to stop pregnancy. But at this stage, if I would have seen, let's say, a kind of cerebellum, even with some clefting without a typical vermis, I would have waited if it's only the cerebellum for later on. This is why we have to be careful. We cannot say we can rule out or confirm Dandy Walker and gestation, but we can have a hint if it's there. Now, there are also many variants, and many of you have seen this since we are looking to the brain. We see the shape of the plexus is different. These images were, in the beginning, suspicious. It could be spina bifida because they were downward. It's not true. The different size, I've controlled many. None of them had any problem. This is something, even if the parents ask you, pass over, there is nothing there. But there are also some borderline findings. You can see that there is such a case of ventriculomegaly, and we can really diagnose some ventriculomegaly in gestation. We don't have reference rate to say this is normal and this is not abnormal. But if you have additional signs, of course you can do invasive, and some may be abnormal. But it does not mean that all ventriculomegaly later on will be apparent in gestation. That does not mean that this ventriculomegaly will be later ventriculomegaly. This was at 22 weeks or 20 weeks. Not ventriculomegaly, it has a schizencephaly and absent septopellucidum with a corpus callosum agenesis and a Blake spot cyst. It has all three things, but not ventriculomegaly. But it was a hint that there is something in the brain which should be controlled. And you can see some chorioplexus cyst, and in relationship with some thickened nuchal and tachycardia, you will find the trisomy 13. That means now your conclusion is it is possible to see plexus cyst in early gestation. No, because this fetus at 13 weeks, and the lady wanted an amnio for previous history, it was absolutely normal, and at 17 weeks it had plexus cyst. Plexus cyst may be there and resolve. They may be normal and then may develop. And many things I will show you today. This is the secret of 11 to 13 weeks. Once you think you know something, you say, I'm sure now. Next day you'll have another case showing you the opposite, absolutely the opposite. And this is why you have to be very, very careful. Let's move to the face. The face, I told you that we look to the face because we measure the nasal bone, the shape of the face. Some measure the angle. And we look at the brain in this plane. I prefer, in addition to the profile, to get 3-4 different planes. And I tell the parents about this. I said, now I show you both orbits. I show you the nasal region with the maxilla, and I go lower and show them the mandibula. And show them, I assume that no large cleft is present and the fetus has 2 eyes at this stage. Because in a profile, you cannot guarantee, not even in 22 weeks. You need to show the eyes. And sometimes, if the fetus is lying in another position, of course you can have a facing like this to watch the orbits. What can we see at this stage? Of course, cases like hypotelorism or even pseudo or cyclopia can be recognized. And from this view here, you can even sometimes recognize the attachment, or let's say the development of the ears. These are the eyes. And this is another condition where you see here in proboscis, you see here both underdeveloped orbits in holoprosencephaly and so on. This is why even if some mild form of holoprosencephaly, you may see the hypotelorism or the problem of the orbit. But it's really rare to have an isolated orbit problem in early gestation. Now, of course, you may recognize some case with a cleft at this stage with the 3D. This is an obvious case where you see the protrusion, and in the cross-section you may see the protrusion. And it was with a thickened nuchal here, trisomy 13. And this case had a normal profile in a way, but in a cross-section we saw the cleft, and this is the cleft at 23 weeks. That means it is not automatically that parents may decide to be against the pregnancy. They have time to get information, to do the invasive procedure, to get the complete information, and not to be hurrying at 22 weeks to get within 1-2 weeks every detail. More challenging is this profile, where you see a small maxilla like a Pierre Robin. Some cases of autocephaly may appear like this. This is why you need to check for the ears as well. But this case, I saw a similar one by Bernard Benoit, and he showed that despite having a very small chin, the development was better. And to be honest, I have to confess, I didn't tell the mother. I told the mother, I don't see the heart quite well. I want to see you at 18 weeks. I say at 18 weeks, the heart is fine, but there is a problem with the chin. And then we did an invasive, and it was normal. We had a counseling and the child was delivered and is okay. But you see, at 22 weeks, the development of the mandibular was fine, actually. And you don't easily recognize the abnormality here, even if I can show you images where it's a little bit, you can see it, but not as pronounced as here. But I'm sure if you show this image to anyone and say, well, this is abnormal, many will decide not to continue for a condition which can be well treated today. The other side of the medal is this image. What is this? I don't know. During the scan, the fetus had this position, and because, sorry? No. And had this position because looking to this thorax, and the same fetus at 22 weeks, and the lady got pregnant again, come with the baby, and the baby is normal. But it was not all the examination. It had normal face, but during the examination, when doing like this, there was some changes that I had the impression this is abnormal. Why? Because we are used to look at faces in a way that they are normal or abnormal. But in early gestation, you may see things which are not there. If it's all the time like this, of course, you may see the problem later on. But listen, my message is, even if you think you are sure, give a fetus a chance to have a control. Unless you have, 4, 5, 6 anomalies, there's something else. But if you have a single thing, then think about the possibility of natural history developing. Now, abdominal wall and tracts. Here, I will check with the magnification to the stomach, liver, to these 3 gray scales, the lung, the liver, and the bowel. And we check for the bladder, for the abdominal wall, and ductus venosus, Doppler, and course. And we can get also cross-section to look at the level of the stomach. Then we go a little bit lower to see the attachment of the umbilical cord, and we go a little bit lower to see the full bladder with both arteries. Sometimes I'm angry that not at the beginning of the exam I didn't check for the bladder, because once you get in your list to the bladder and it's not full, you have to wait until you see it full. This is why go and do it easier, that as soon as you put the transducer, you check for the bladder. In general, this is some empiric observation tells me that boys have rather more full bladder during the examination than girls. This is why they will empty easier. Once you see, let's say, often a full bladder, you may suspect it's rather a boy. But you can get your own experience on this. Now, these are things which are easily detectable: omphalocele, gastroschisis, abdominal wall defects. You go transvaginally. This is not a big problem because you see it easily, but the counseling it may be difficult because people think it's too large to be operated. But believe me, all can be operated today with good results. This is why there is no reason to stop pregnancy unless you find additional things. The tiny one are more tricky because they may be a sign of chromosomal aberrations. That means this one is easily to detect, but may have a good prognosis. This one is not easy to be detected, but may be related to a chromosomal abnormality. The main problem is when you do, for example, 3D, if it's very high, it may be more part of a laparoschisis or abdominal wall schisis, where a part of the pericardium, even the heart, as a micro form of a contrail pentalogy may be found. Now, what is the prognosis? And here we should learn, because we assumed at the beginning, well, we tell the parents what you know about omphalocele. It's not true, because you have to relearn. And we had some lessons in the past, and this is what we presented in Prague of roughly 50 cases. 39 were terminated because of additional problems like chromosomal anomalies and so on. And the 10 cases where we assume they are isolated, 5 at the end had operation. That means 5 out of 50 means 10%. 10% will reach the surgeon. 2 died at 30 to 32 weeks. They were prepared and had counseling and so on, and they go probably because of the movements and some reaction of the vagus. And 3 had malformations. We haven't seen them before. One case I saw myself had a diaphragmatic hernia, not present before, not seen before. One had a tetralogy. I scanned her several times and saw the tetralogy first at 19 weeks. Probably because of the shifting, you don't have the typical planes. This is why you have to be careful. And this is why the optimistic approach of saying, oh, don't worry, we'll do it at 22 weeks is the one surviving all these ones. This is why we have to rule out step by step and then make the last check at 22 weeks. So then when we look to the stomach, we should do it in relationship to the heart. Now, the stomach is nice here, but it's on the right side. And this is something, believe me, it's so hard to recognize transvaginally if you don't have an excellent orientation. This is why I would recommend you to check the isomerism stuff and so on abdominally, because you can see the orientation. And then you see here the stomach is on the right, the heart is on the left. The heart has a problem, and this is typical of isomerism. Even you don't lose your time checking what's going on in the heart. Here, this is a complex problem because you have upper abdomen and the heart at the same time. This is more tricky to detect a complete situs inversus without additional things. The stomach on the right and the heart on the right. And this was done by abdominal, and she had the previous history with a cardiac problem. Now, once we look to the abdomen, if we move downward, we see the typical image of megacystis, which is the obvious first diagnosis we do. But we have 3-4 different diagnoses we should consider. Not always this is the bladder, even this was the bladder, but here you see there is something else, and this is not the bladder, this is the bowel. They appear similar, and this is why we know the diagnosis of megavesica, but it's not always the same. And if you take a volume, you will see that we have here a kind of, but this is the bladder, and this is another structure, and this is a dilated bowel. And what is the difference is if you go transvaginal, you will see the wall of this structure is more echogenic. And sometimes you find things inside. And this is a bowel obstruction, a low bowel obstruction. And unfortunately, this lady didn't want an invasive. She came, and she was very young, and she decided not to come. And then she said, yes, I want an invasive, and so on. But she came, and she decided not to have. This was at 17 weeks, where he said, now we have to decide because we cannot continue pregnancy like this without knowing. And she decided to terminate pregnancy. But I wanted to show you that it appears as a megacystis, but think about a cloaca, think about a bowel obstruction. The cloaca will be similar to the bladder, but within, let's say, the shape is abnormal. And the bowel, you will see the echogenic wall, and you see some debris inside and other dilated bowels. Now, a very challenging and interesting topic are the cysts, especially they are in general in the liver. The first time I saw such a finding, I assumed never will do it, and it was probably 15 years ago, we assumed we have to go with a needle to puncture them, otherwise we cannot rescue the baby. Don't do anything, wait. What we do in these fetuses here, we check for CMV, we check for cystic fibrosis, and we check for chromosome, and we ask them to come back. This was 13 weeks, this is the stomach, this is the liver. At 16 weeks, nothing. If I did the puncture of this problem, I would have said, yes, this was my merit that the fetus had nothing. But it was, I was preparing to do the puncture on that day, and it was disappeared. And I saw several cases. And one day I got a phone call from a colleague, said, I have a patient now in treatment, and she's at another center. They want to puncture that. Don't puncture it, it will disappear. And this is, he gave me this case. This was at 14 weeks. And they did the puncture, and 2 weeks later, 16 weeks, this was the huge cyst. Said, I will continue because it's not an ovarian, they assumed an ovarian cyst, not ovarian cyst at 16 weeks, and I will wait. And she came to see me after 20 weeks, and this was the cyst at 25 weeks. If you tell the neonatologist there is a huge cyst in the baby, and this was the cyst 34 weeks. This is nothing. We observed only, and it disappeared. Now, if you go to ultrasound, you say where they have seen the cyst, there is no cyst of, and this disappeared. This needed longer time. I want to tell you that some things may be so severe and may disappear, but some other things may be opposite. They may be normal, and then maybe they're later abnormal, especially the renal system. Personally, I hate the renal system in the religious state because you may think you see things, but it's always, you will lose always. When the problem is there, it's always very difficult to say because you assume you have seen the kidneys, but they are not there. First of all, they are a little bit more echogenic. This is why they are easier to see than in second trimester. You may see some pelectasis, but most of them will disappear. And this is why we check mainly the full bladder, which is very, very important. We check for the presence or absence of both umbilical arteries as sign of possible renal and cardiac problems. And if I see an empty bladder, I will control. I don't write, like in the past, empty bladder today. I want to have the baby, when I finish, at least once seen the full bladder. And this is here, large bladder to get the control. Now, show you two cases. These two cases had always an empty bladder and the typical parallel shape of the vessels. Why? Because the bladder was never full. And the bad news is that the amniotic fluid is normal. So, I examined the fetus. I didn't find any kidney. Found here the flat adrenals and no renal artery. Theoretically, it could be pelvic kidneys and the bladder not well filling. I said, I told the mother, to be honest, I think it is an absent kidneys, but if I send you at the center and you have normal amniotic fluid, no one will terminate pregnancy for a renal agenesis because of normal amniotic fluid. What we can do, we'll wait until it disappears. And she came weekly, and at 16 weeks there was no fluid, and she went to the center. For me, it was easier. But I've seen, let's say, 2-3 other cases. They had additional findings like radius aplasia and so on. They didn't want to wait. This is why, if you look at the kidneys, you can see them very easily, not abdominally, but mainly transvaginally. This is here the normal finding in case using color. But I will not trust this if I don't see the kidneys on 2D. This is only to confirm, yes. I'm not telling you use the color to check the kidneys. I'm telling you look at the kidneys, you can see them. Or indirectly see the bladder between the vessels, and this is the first step, and then at least you can recognize some echogenic kidney. In some suspicious cases, you may recognize the horseshoe kidney because it is more echogenic. You can see it well. Specifically if you are seeking for trisomy 18, for Turner syndrome, or for previous history. But on routine, you may see it if you want, but this is something you see rather transvaginally than abdominally. You see here again a horseshoe kidney. And another bad news are these two kidneys. This is normal and normal appearing kidney. This picture I've done because it was just before CVS. I know the lady because she came to me a year before. I saw at second trimester at 22 weeks a large multicystic kidney. It was an autosomal recessive polykidney disease. The baby died. We had the molecular genetic result, and she came for a CVS because she has a recurrence risk of 1 to 4. These were the kidney, but the result was positive. That means these are early forms of autosomal recessive polykidney disease, exactly similar to the other one. If I mix the images, you will not know. And this was the image of the previous child. That means these are going to develop in this way. The problem is that even if I see them well, I can't tell you it's going to be bad. It will be cystic. This is why we cannot do the diagnosis in early gestation. Even sometimes it developed late. And this was a fetus with other abnormalities. There was no apparent problem of the kidneys, and at 18 weeks you see the multicystic kidneys. This is why if you want to rule out multicystic kidneys, you cannot see them in early gestation. Disappointing. Next point is some cases of megacystis. You see 12 weeks, invasive, was normal, and the kidneys appeared normal. We said, let's control it soon, and she came at 14 weeks. And this is the unexpected, is that it was normal, and the child developed normally, and because she's a medical doctor, I know she came with the baby. Everything was during the pregnancy normal and afterwards normal. She said here, she was afraid, said, I'm more afraid than you because I cannot tell you that it will go the normal way. Interesting, it disappears. But the disappointing is really, this is something which kills us sometimes. You have a nice nuchal measurement, 39-year-old lady, everything looks normal, and the doctor calls you, oh, I see a megacystis. No, it's not possible, megacystis. No, everything was ruled out at 12 weeks. And this is at 15 weeks. I did a puncture of this. Later on, the kidneys appear slightly echogenic, but they were normal. At 25 weeks, they stopped to grow. At 30 weeks, no amniotic fluid, lung underdeveloped, and the baby died 5 days after birth, or 2 days after birth. And it had a normal. And a similar case we have seen last 2 weeks. This was scanned by my colleague. A normal scan. This was the confirmation the bladder is full. And 12 days later, he got a phone call, and this is the megacystis. And looking to the kidneys, they were bright, echogenic, a little bit enlarged. And she went yesterday for termination of pregnancy. Because, this is a renal dysplasia with megacysts. That means not all cases of megacysts are present as early as 12 weeks. Even a week later, you can switch. You see here it's from 8th of February. Skeletal system is a little bit easier but more difficult to do because you can see here the hands and the limbs very well, and you can see the fingers, but you should seek for them. And I do it easier in early gestation than later on, because later on at 22 weeks, if the fetus is sitting like this, you are not always able to see the hands. And I had one case I saw 6 years ago, and I learned from this, and actually one learns more from the cases missed than the cases you see, is that in early gestation, the nuchal was 2.6, and she came for amniocentesis. The amniocentesis were normal, and at 20 weeks, it was an Apert syndrome. And I was not looking to the hands in a way that I see the fingers. Since then, I'm trying to see the separate fingers like this. Where I see the thumb, I see the fingers, and then pass over. Otherwise, it's really easy to see in early gestation. What you need to do sometimes, if you have a very good transducer, to reduce the power, because if you have a lot of power, there is an overlapping of the grayscale. And sometimes, let's say, I don't show only one hand. I try to get on one plane both, either in a cross-section, because I had several conditions where the patients, when they are outside, said, you showed me the hands, but are you sure that you showed me two separate hands, or you showed you the same hand? And then to repeat again, to let the woman come back to scan her. This is why, since then, I show them, look at the face now, I move, I show you both hands on the same time, and say, yes, I saw both hands. Or if you do 3D, you see at least the shape. It's not 3D to see the nice face, but at least you see the two limbs, two arms and legs, and you have documented. And in these conditions, of course, you may recognize the cleft hands. You may see some polydactyly. It's probably sometimes easier than second trimester when they are doing like this, because it may go lower. And in the legs, the same. Here you see also typical radius aplasia, and club feet are not so really detectable in urgency. You may see, but some fetuses may have a kind of club foot, which is not yet the case. Well, typical images are the one with the serinomelia, where you have one leg. Here we had reduced amniotic fluid. This is why the images were bad. Or if you have bilateral radius aplasia, it's easy to detect. If you have unilateral, it's really tricky, because you will scan and you think, oh, the hand, I've seen the hand, and you assume the other one will be normal if there is nothing else. But we had several cases where one hand was like this, and this is also detectable. And this is why I do both. This is the normal hand, and this is the other hand. And you see here that on a 3D, you see exactly what's going on, that there is a ulna and femur fibula, short femur and absent leg and absent arm. This was the nurse of one of the gynecologists in the city, and said, oh, I'm trying to check, go to him to have nice images, and this is what was the result, unfortunately. Polydactyly, this fetus had nothing else. We did the diagnosis and invasive and so on, and she had a previous history of Down syndrome terminated, and she was unlucky that something else and so on. But she's a very nice person. She wrote me a letter with a logo on it, give me 6, like give me 5, and with the print of the hand. So, and then now the boy is 1 year old, and last week she sent me a new 1 year anniversary of the child. And this one was related to microdeletion 22q11, and this was the first step, and then I watched the heart and I saw some tiny abnormality. I'm sure that some brachydactyly is not detectable. If I didn't know that the woman has herself this and her father, and it autosomal dominant, I checked for the fingers and they were the same. But the fetus had, in addition, hypoplastic left heart syndrome, which is not related, and she decided to stop pregnancy. This is why I don't have a confirmation after birth. This was a surprise because everything was normal, and by measuring the femur, it was short. And we made the follow-up, and then later on, we saw the polydactyly, and it was an Ellis-Van Creveld syndrome. And interestingly, the ribs were also short, but they appeared a little bit later. That means the limbs can be well recognized even at 11 weeks, and all the details. But you should examine them thoroughly because there is no typical signs to be checked. And remember that in later gestation, you may have some other skeletal measurements which may show you in direction to check for the limbs, and the polydactyly may be also missed. Now, at 15 weeks, you see these short ribs, but the same fetus as 13 weeks had normal size of the chest. This is why we didn't assume. We said, well, we have only short femur and short humerus. We don't know the reason. At 15 weeks, we showed the short ribs. Then I found the polydactyly, and we checked for different reasons, and they found the Ellis-Van Creveld syndrome. This is why some things develop. But recently, I had a fetus at 13 weeks having already short ribs and the short limbs, but we don't know yet the final diagnosis. I will finish with the thorax, with the heart and lungs, and you can imagine that I can give a complete talk on the heart in early gestation. But the message is that you move from the face down to the thorax, you get the 4-chamber view, you move a little bit higher to get to the 3-vessel view. And I think that the most important planes are really these 2 or 3 ones. That means the 4-chamber view on 2D with the septum to see both chambers and to see the relationship, and to get the 3-vessel view where you see the direction of the vessels toward the trachea. And this can be done transvaginally, as on the left, or transabdominally, but you need a good preset. And this is why instead of saying, no, I don't examine the heart, take your time and do it. This is more easy than you assume. Of course, in talks, we show you good images, but you need roughly to see that there are 2 chambers, and you need to see that the great vessels are raising properly. That means you see the so-called V, blue V sign. And once you see here this condition, you have ruled out many of these anomalies. If you see this condition, you are sure that there is no single ventricle with an absent aorta, or let's say severe hypoplastic left heart, or hypoplastic right heart, or etc. I'll show you some examples. Now, the 4-chamber view, normal. The 4-chamber view with an AV septal defect. This should not be your diagnosis. Your diagnosis should be on 2D, confirmed by color Doppler, because in many machines you don't have the adjustment to be sure that this is not the same here with a more gain. This is why you should remove the color and confirm that you have a single AV valve. Here, you can do what you want. There is no single chamber, and here there is a narrow chamber. The same for the 3 vessels. We'll see this tomorrow. You have here the narrow aortic arc in coarctation. You have the reversal flow in hypoplastic left heart with the aortic atresia. And you have the aorta going to the right and the pulmonary going to the left. And you see between them is the trachea, which is here in this condition. Of course, you tell me, oh, I'm not able to see the trachea at this stage. But you see that this is not a typical V sign, and there is some tissue between the vessels, and this could be seen. Now, what I do, like the other conditions, when I suspect overriding and a narrow pulmonary artery at 12 weeks, I recalled the lady later on at 14 weeks. I did again transvaginal, and then I wrote my final diagnosis. I'm sure, but I learned a lot that, let's say, my uncle used to tell me, remember, Rabbi, later in your life, what you hear, don't believe anything, and what you see, believe only the half of it. And the time of digital era of machines and so on, really, there are things you see, you think you know it's true, but it's not true. This is why, be careful, because sometimes you may have a normal finding and you have only some overlapping of the color. And then you say, yes, it's a tetralogy and so on, unless you have additional findings, of course. And again, this was the wrong knob. And this is here, 13 weeks abdominal, right aortic arc with the trachea between. Once you know how to look for, you can get. Here also the secret is to reduce the gain, that you don't have a lot of... how to move from second to first trimester. You know the planes, the 4-chamber view, the 5-chamber view, and the 3-vessel view at 22 weeks, and you do the same at 11 to 13 weeks. You get the 4-chamber view. This is not, for me, always obligatory, because I'm not sure to get in all fetuses the ascending aorta because it's tricky, but this is obligatory. This plus this plane are in every fetus as can standard, should be, because in this one, I rule out a single ventricle and a severe problem, and this one I rule out the major conotruncal anomalies, common trunk and so on.
If you have a tetralogy here, I may not see it's overriding. I see here that it's narrow pulmonary artery. Otherwise, if it's mild, so what? And there are conditions you don't need to see them. Even if you miss a transposition has no chromosomal anomalies and has a good outcome. The problems are the one who may be related to chromosomal anomalies and so on. Okay, then show you some pitfalls. You know this example of a normal four-chamber view at 12 weeks. Pulse Doppler showed me that they may be in aortic stenosis. A later control of the same fetus, you see the normal contractility at 19 weeks, shows the hypoplastic development of hypoplastic left heart syndrome from first to second trimester. The other side of the medal is this fetus, thickened nuchal 11 week, 5.4 at 11 weeks. The heart, as you see here, a pericardial effusion, a narrow left chamber, I suspected a coarctation and assumed, probably a Turner. It was not a Turner. And she returned back. It was here, when was the date? 9th of March last year. And she came back end of March. And this was the nuchal. Well, I put it here. I could have put it here to say 2.3, but normal nasal bone. And the heart, normal. I controlled her at 22 weeks. I controlled her at 30 weeks. She sent me a letter. Everything is normal. I still do not believe. Because, to be honest, another woman would have said, 6 millimeters with an abnormal heart. I don't want to pregnancy. And many one will sign because there are numbers. And the child is healthy. But I think sometimes that 11 weeks thickened nuchal, let's say improving to 13 weeks, is something different than the 13 weeks 6 millimeter, which are really true. This is why I think that later on we'll see that some 11 weeks problems or normality are quite different than 13 weeks, where things are rather typical like the second trimester. Now the lungs are more tricky because you may see some hydrothorax in some diseases here, like Turner with a narrow chamber. You may see diaphragmatic hernia, but the lungs are not a field of early gestation, because all cystic malformations are not seen, all sequestration are not yet seen. Even diaphragmatic hernia is not easy to detect. Here you see at 13 weeks plus a shifting of the heart. But you see here this, what I found here in this fetus is that I didn't like the shape of the vein within the liver. But if you look at carefully, you see the stomach is here and the heart is here. There is no heart shifting. But if you move to a longitudinal view, you see here the esophagus and the stomach has not yet moved the heart to the right side, but has already left the upper abdomen to move into the thorax. That means the lungs are still normal, and probably this is the stage where we may think about early surgery then later on, because the lungs are still normal at this stage. This is why, in the meantime, I prefer to look at the lungs and to the stomach in longitudinal view to rule out this from this condition where the stomach is in the up. So I come to the end of my talk. Limitations of early anomaly scan is that the comprehensive anomaly is time-consuming. This is not something you do rapidly because you measure the nuchal, you measure the nasal bone, and you finish. I think the problem is that we have always to repeat the scan later on, but I feel by far more confident I have done on myself, let's say, a check in early gestation. And the good news is that if you doubt, you don't need to handle today. You can ask to have a control 2-3 weeks from now where you know how things appear at 16 to 18 weeks. What are the anomalies which are not or yet detectable, like agenesis corpus callosum, the Dandy Walker, the schizencephaly, the complete brain problems because the brain is still developing and events can still happen. Lung abnormalities are not the field of early gestation. I told you that diaphragmatic hernia may develop later. That means you may have, let's say, a gap, but the bowel will go up later on. And the kidneys is really something where you can't say anything unless that there are 2 kidneys and the bladder is full. And the cardiac anomalies may be also abnormal. So in my conclusions, I hope I showed you that the 11 to 13 week scan is more than measuring the nuchal, that many anomalies are easily detectable, but we have seen that you detect better if you do a checklist and an approach, but you have to learn that there are some abnormalities which resolve,
and some you think is normal, and they may appear, even if some of these conditions may be apparent in early gestation. You may see megacystis at 12 weeks, but a normal bladder does not rule out a megacystic development at 14 weeks. And I said one of my talks, my proposal, if I had 1 hour time, I would do 45 minutes early scan and finish everything and then do rapidly the second trimester. Because at second trimester, the way I work is really, to be honest, 1 minute. I put the scan. I looked first. The brain, cavum septi is there. I looked to the heart, no problem. I looked to the abdomen, no cystic problems. And the fluid, no hydrops. And that's it, because you know that there is no spina, there is no absent septum pellucidum, the heart is normal, there is no cystic problems in the abdomen, and you feel comfortable. There are really some tiny things, but major anomalies were done in early gestation. So I thank you for your attention, and we can have both talks for discussion now. Thank you.